Welcome back in another discussion of management of pulmonary tuberculosis and extrapulmonary tuberculosis. So overview, we will just discuss some basics. We will define the PTB and EPTB. We will look for the clinical presentation, what is the diagnosis, what is the treatment, and we will also take up your questions. If you have any questions, any query, just put in the comment box and we will try to discuss accordingly. So if you see the burden of TB in India, as of now, where population is over 140 crore, so almost 40% are infected with tuberculosis. Incidence is for year 2021 is around 210 cases per 1 lakh population. Now it has gone up to 310, 312 per lakh cases as per recent data. And approximate 28% of the world new TB cases occur in India. 30 lakhs new TB cases each year, you can see, and estimated 5 lakhs death per year. So, and we know that around 40% of the population infected with TB, almost half of population has some infection of tuberculosis. So, TB kills more adults in India than any other infectious disease, and on every day, if you just calculate the data, more or less, more than 6,000 patients will develop TB, and there is a more than 600 deaths per day. So, that makes 2 deaths every 5 minutes. So this tuberculosis. We know that tuberculosis is a disease caused by Mycobacterium tuberculosis and it spreads from person to person through air. And the Mycobacterium tuberculosis is a bacteria or TB germ usually attack the lungs. However, TB germs can attack any part of the body such as your kidney, spine or brain. Pulmonary tuberculosis is the TB in the lungs and extrapulmonary tuberculosis is the TB places other than the lungs like your kidney, spine and brain. Important point is not everyone infected with TB germs becomes sick. So then we should also know that how TB is spread. So TB is usually spread through air by aerosol transmission when a patient infected with tuberculosis coughs, sneezes or sings, and by this way it emits your Mycobacterium tuberculosis bacilli and that is gets inhaled by a susceptible host. So this is how TB is spread. So this aerosol transmission is very important. So remember always it is a pulmonary tuberculosis patient that have a capacity or only pulmonary tuberculosis patient can transmit infection to others. Extrapulmonary tuberculosis cases, extrapulmonary TB patient cannot transmit disease. So this is very important that their extrapulmonary cases are not infectious. So if you look for possible TB symptoms. What are the symptoms of tuberculosis? We know that night sweats, low-grade fever, chills, weakness, fatigue, weight loss, loss of appetite, anorexia, cough lasting for more than 3 weeks, more than 2 weeks also. It's now cough more than 2 weeks, chest pain and coughing of blood or sputum, that is hemoptysis. These are the possible common TB disease symptoms. Plus, if you see, there are also site-specific symptoms, especially in the case of extrapulmonary tuberculosis. So what are the site-specific symptoms? For example, if somebody has CNS tuberculosis, so they will have a headache, seizures, or they may present like your weakness or a cranial paralysis. And if somebody is having lymph node tuberculosis, so they will have a lymph node swelling of a particular site. So common TB symptoms plus site-specific symptoms will be there in case of extrapulmonary TB cases. So what are the risk factors? Very important to know that who are at risk factor for becoming infected with TB germs. Important point is anyone can get TB, anyone can get tuberculosis, but some people have a high risk of getting infected with TB, like people who have a contact with someone who has infectious TB case, and people who are born or who are frequently travel to the countries where TB is common and having a high prevalence like your India, China, Haiti, Guatemala, and other countries with a high rate of TB. So these are the countries having a high prevalence of tuberculosis, and if somebody is having a frequent traveler to these countries and presenting to us with the possible symptoms of tuberculosis, and then we should always look for tuberculosis as a diagnosis. Another is the healthcare workers and other who work or live in the place at high risk for TB transmission, such as homeless shelters, jail and nursing home, because overcrowdings, because of the overcrowding in the jails and in nursing homes, so that makes, and in the shelter home also, it makes patient more prone to get tuberculosis because of the overcrowding and poor ventilation. There is another risk factor that who is at risk for developing TB disease. People at high risk for developing TB disease generally fall in the two categories. Number one, those who have been recently infected with TB germs and those having certain medical conditions that cause weakened immune response, because we know that immunosuppression or weakened immune system is a strong risk factor for developing TB disease. HIV infection is one of the common. Substance abuse, if somebody is having IV drug abuser, that also weakens the immune system and making patient more prone to get tuberculosis. A specialized treatment for rheumatoid arthritis or Crohn's disease, because in these conditions immunomodulators sometimes and immunosuppressant medicines are used. And organ transplant patient, somebody has received solid organ transplant like your renal transplant, liver transplant, and these patients are again at the high risk for developing tuberculosis. CKD is an immunosuppressive state that makes patient more prone to get TB disease. Head and neck cancer, diabetes is a very strong risk factor for developing TB disease. And medical treatments such as corticosteroid. If somebody is on corticosteroid treatment for some indication, that also makes patient to prone to get tuberculosis. Silicosis is again a risk factor. Low birth weight is again a very risk factor, because in low birth weight, what happens? Low birth weight, malnutrition, it causes more prone to get tuberculosis. Again, in tuberculosis, we know there is a weight loss. So there is a vicious cycle. Low birth weight, tuberculosis, and tuberculosis again causing low birth weight. So this is very important to take care of the nutrition of the patient also. So how to classify a TB case? That is very important, because first we have to classify the case based on anatomical site of the disease. So we have a two classification. One is pulmonary tuberculosis, that is we call any microbiologically confirmed or clinically diagnosed case of TB involving lung parenchyma or tracheobronchial tree is called as a pulmonary tuberculosis. And extrapulmonary tuberculosis is any microbiologically confirmed or clinically diagnosed case of TB involving organs other than the lungs like pleura, lymph node, intestine, genitourinary tract, bone and joints, meninges of the brain. So this is called extrapulmonary tuberculosis. Again, we classify the TB patient based on the previous TB treatment, and that is important for us for treatment purpose. So new case is a TB patient who has never had treatment for TB or has taken anti-TB treatment or anti-TB drugs for less than 1 month. So all these patients we call as a new case, and previously treated patient who have received 1 month or more of anti-TB drugs in the past. So these are all patients who have been received more than 1 month of anti-TB drug are classified as or categorized as previously treated patient. What is a recurrent TB case? A recurrent TB case is a TB patient that was previously declared as successfully treated, that was treatment outcome was cured or treatment completed, and is subsequently found to be microbiologically confirmed TB case. So these are called recurrent TB case. Important point is, in recurrent TB case, always rule out MDR, multi-drug resistant. Alright. Now, how to diagnose pulmonary TB is very important. It is a stepwise process that starts from your clinical history, classical symptoms and signs, physical examination, then your basic blood work, doing CBC, LFT, RFTs, RBS, HIV, doing chest X-ray and sputum examination, sputum for A, B and CBNet examination. So we have just discussed what are in the history. The typical symptoms of TB may include, general symptoms are fever, lethargy, anorexia, weight loss, enlarged and tender lymph node. And if the patient is having pulmonary tuberculosis, there is a classical cough that lasts for more than 2 weeks. There may be sputum production that is initially dry, purulent or blood stained. There may be breathlessness. There may be pleuritic chest pain. And here we can see the classical tuberculosis symptoms. There is certain important point to ask in the history of pulmonary tuberculosis. What are these important points? If you look for the fever, it is a classical low-grade evening rise. Cough, insidious in onset, lasts for more than 2 weeks. Hemoptysis, if somebody is having hemoptysis, you should always ask for onset, duration and quantity. Weight loss, very important, that unexplained and unintentional weight loss of more than 3 kg in the previous 6 months is known as significant weight loss. So remember that weight loss should be unintentional and unexplained. For example, if somebody is on weight loss program, somebody is doing gym or a diet restriction for weight loss, that weight loss is not called significant. And significant weight loss in clinical medicine is always a red flag sign. If somebody has a significant weight loss, always think there is some serious problem with the patient, and you will find some serious diagnosis in such cases. If you look for the Harrison, it says loss of 5% of body weight over 6 to 12 months should prompt further evaluation. So if somebody has lost more than 5% of the body weight, in the last 6 to 12 months, you should always do a rapid assessment and you should evaluate for the cause. Plus, there may be associated general symptoms like fever, lethargy, anorexia, weight loss, enlarged internal lymph node. That is the common symptom sometime in case of tuberculosis. If you look for the chest X-ray, this is very important. If you see the Ravan, it has a 10 heads. So it is just like a great masquerader. What does it mean? It means any abnormal shadow can be present in the chest X-ray. Alright. So, but there are some very typical cases are there, just like your cavitation of the upper lobe. TB is a upper lobe disease most of the time, and also it can present like you can see bilateral upper joint consolidation. But very important to know, any abnormal shadow in high prevalence countries, including India, must be evaluated for number 1 tuberculosis, number 2 tuberculosis, number 3 tuberculosis before moving to other diagnosis. And again, we should also offer the sputum examination in the form of smear for AB. Here we can see in the examination, you can see the acid fast bacilli in the smear. We can do a gene expert, we can do LPA, that is line proboscis, first line and second line, depending on the clinical indications. So if you look for the diagnostic algorithm for pulmonary tuberculosis as per NTEP, all patients with presumptive TB, there is a NAT is a preferred test. So what is NAT? It is your CB NAT. So all presumptive TB patient means those who are having symptoms of tuberculosis, NAT is preferred. Doing a CB NAT, then you can do microscopy and chest X-ray also. So NAT is always preferred in such patient. Okay, NAT testing is done, and if NAT testing is done, if you see here, there may be MTB positive, rifampicin sensitive. So in all these cases, who are having MTB positive, rifampicin sensitive, you will order a first line LPA. First line LPA to look for the isoniazid sensitive and isoniazid resistant status. If it is isoniazid sensitive, that we call as a DSTB, means drug sensitive tuberculosis, and we will treat accordingly. And if it is coming to H resistant, that we call as a isoniazid monoresistant case or polydia TB also. So in that situation, treatment is different. If on CBNAT MTB is positive and rifampicin resistant is seen, then we have to do a second line LPA to look for the fluoroquinolone sensitivity. If fluoroquinolone sensitive, we call it as a MDR or RRTB. And if it is fluoroquinolone resistant, we call it as a pre-XDR or XDR TB. And we treat this patient as per your PMDT guideline. Fine. And all these MDR patient, we subject this patient for, we send the sample for first line LPA, second line LPA and liquid culture DST. And if you do X-ray, if there may be lesion, X-ray is finding suggestive of tuberculosis, and then we can call as a drug sensitive TB and we can treat. However, if X-ray is negative, X-ray does not showing any lesion, microscopy, NAT and chest X are negative, we have to check for the other causes, or we have to think of clinical diagnosis in tuberculosis in such patient. Alright, so this is how we should follow algorithm as per NTEP to diagnose. All such patient we have to look for upfront NAT test. If you do upfront NAT test, means all these patients must be subjected to your CB NAT, sputum for CB NAT to rule out rifampicin sensitive or rifampicin resistant status. That is called upfront NAT test. So there is a utility of this. We can, number one, we can diagnose a tuberculosis confirmatory. We can diagnose tuberculosis. Also, we will able to know the rifampicin status or resistant cases, and that will help us to categorize and classify the patient also as a drug sensitive tuberculosis or drug resistant tuberculosis. It comes to drug sensitive TB treatment regime. So if you see treatment of TB cases, so type of cases being new and previously treated. So treatment regime in IP and CP. IP is your intensive phase, CP is your continuation phase. So in IP, 4 drugs, isoniazid, rifampicin, pyrazinamide and ethambutol for 2 months, and in the CP phase, 4 months of isoniazid, rifampicin, ethambutol. And in previously treated case, the regime remains the same, that is 2 months of HRJD and 4 months of your HRE. So what makes the difference here? So in all previously treated patient, we have just seen that all the patient who has a diagnosed case of presumptive TB are offered CBNAT testing upfront. So in previously treated also, you have to rule out MDR tuberculosis by doing appropriate CBNAT test before prescribing the regime. So that is very important point. So here are the weight band. As per the weight category, 25 to 34 kg, 35 to 49 kg, we give the FDC depending on the weight, 2, 3, 4, 5 tablets in the IP and accordingly in the CP phase. So that is very important. If you see here, in NTEP for adults, 4 FDC given in IP that consists of HRJD and 3 FDC given in CP that consists of HRE. And that is very important. During treatment, if weight of the patient increases by more than 5 kg and crosses the next weight band, the patient should be given to the next higher weight band FDC drug. So if somebody has gained weight and crossed the weight band category, then that ATT must be modified as per the weight of the patient. And if you look for the drug doses here, for NTTB, first line NTTB drug, for isoniazid, dose remains 5 mg per kg per day, 4 to 6 is your range. Rifampicin 10 mg per kg per day, 8 to 12 is your range. For pyrazinamide, it is 25 mg per kg per day, ethambutol 15 mg per kg daily, and streptomycin 15 mg per kg daily. And streptomycin is administered only in the certain situation. Actually, it is not used as a first line. It is reserved for certain situations like patient develop drug-induced hepatitis and in a tubercular meningitis, and patient develops adverse drug reaction for the first line drugs when first line drugs cannot be used because of the adverse drug reaction. So nowadays first line drugs are only 4 drugs, that is isoniazid, rifampicin, pyrazinamide and ethambutol. Streptomycin, amikacin being your second line drugs. Alright. Now important part here is all these patients who are on anti-TB treatment must be provided with your pyridoxine in the dose of 25 mg per day for adults and 10 mg per day for pediatric patient during the entire course of anti-TB treatment to prevent isoniazid induced neuropathy. That is very important. Okay, because isoniazid cause neuropathy. So here are the 4 FDC. You can see 4 drugs, and this is your 3 FDC that is used in your CP phase. Again, pyridoxine at dose of 25 mg per day for adult and 10 mg per day for pediatric for the entire course of ATT. This is the weight band category that we follow. If you see for the adults more than 18 years and for the pediatric population. So to conclude, TB is a common health problem in our country, and always evaluate pulmonary tuberculosis in the patient having cough for more than 2 weeks. Any chest X-ray finding can mimic tuberculosis. TB treatment is needed to treat tuberculosis effectively, and yes, by following the NTEP guidelines, we will able to achieve our target of TB Mukt Bharat by following NTEP guidelines for treatment and diagnosis part. Alright, so this is all for today. In the next session, we will discuss about your programmatic management of extrapulmonary tuberculosis. We will take up the different extrapulmonary TB cases in one by one, and we will discuss how to manage such cases, including diagnosis and workup also. So stay tuned and see you all in the next video.